So I get the honor of introducing my good friend, Peter Vajkoczy. This picture is from previous times, obviously. Actually, it goes back 7 years. I've known Peter. Peter's born to Hungarian parents and has grown up in Germany. And when I first met Peter around 2006, he was a rising leader in the German neurosurgical community in Mannheim, Germany, working for Dr. Schmiedek, who is sort of a luminary neurosurgeon, not only in Germany, but in all of Europe. And Peter was his best pupil, and he became chairman in Berlin. At the time was I think to this day still have an east-west structure where the old Charité hospital in East Berlin is part of the newer Western Hospital of Benjamin Franklin. And Peter's job was to go in there at the age of, I think he was less than 40, or around 40 years old, to go and try to create collaboration and be a leader in a very challenging environment. And not only has Peter done that, but knowing him and getting to know him over the years, he's certainly one of the most talented, gifted, ambitious people that I've ever met, potentially in the world. His talents are unique. He's become an academic spine surgeon after what's happened in our vascular world. And there are a few people that I respect more than Peter and what he's done. He's overcome obstacles, many of which you wouldn't even imagine. And I'm so glad that he could come and give us a European perspective. You know, when New York was going down, Peter called me and said, "What are you guys, crazy for shutting down elective surgery?" before it really became obvious. And you know, I think that he's learned a lot along the way as well. And obviously the experience in Germany has been very different from here. But I think his perspective, the European perspective, the German perspective will be very valuable to us here in the States. And we're so grateful for you giving us the time, Pete. So thanks for joining us. You can take over if I can stop sharing my machine here.
I'm trying to start this. It obviously doesn't work.
You click on the share screen button down at the bottom.
I clicked it. Oh, shit. I clicked.
Huh. Maybe I'll close mine and just, if I close out, I'm off, but I'll close out and then.
Okay, I'm in.
Here you go.
Okay, David, thank you so much for inviting me, and thank you very much for these kind words. But if there's one thing that I deserve credit or acknowledgement, that was to bring you into this tent at the Oktoberfest, which was very crowded, and we were trying to sneak you in, and this worked. So I think this is the one thing that I owe credit, that I should get credit for. So thank you very much for the invitation, and dear colleagues. You asked me to give a European perspective, and number one, I'm glad to participate because through the Netflix movie, I learned that you are a real surgeon. I always thought that you're just telling stories, but now I'm convinced. How can I proceed? Here. So this is one of my images that I would like to start with, or acknowledge you as my very good friends and highly talented surgeon. We know each other for a long time, and I can give you the compliments back that I admire you very much. But interestingly enough, this picture also shows the Italian group. And as you know, in Europe, the Italians were the first to be hit, and they were the hardest to be hit. And here you see Professor Tomasello from south of Italy. And as you mentioned, we Germans, we were intensely discussing how to behave best and what's the role of the neurosurgeon. Most of us did not become COVID doctors, but tried to stay neurosurgeons. And these are my best two friends, Carlo Schaller from Geneva and Bernhard Meyer from Munich, who always helped me to have a compass and to know which direction to take. And I owe them a lot of credit for the talk and for the decisions we have made in the last weeks. So I will start with the development of COVID-19 pandemic in Europe. And as you know, Europe is not Europe. Europe consists of many different countries that have sometimes different opinions, opposing opinions. But during the pandemic, this seemed to be negligible because everything started in February when these images reached us. Hospital staff that was exhausted, patients dying in a high amount or in a large majority, and especially the fear of triaging. Triaging is something that we are used to, but politicians for the first time realized that there is something like triaging, that you have to decide which patient has to go on the ventilator and which would not go onto the ventilator. And in Europe, and specifically in Germany, it became clear that at any price, pictures like this have to be avoided in other European countries. And in addition to this rational approach, to this political approach, we had these individual contacts from our friends from Italy that told us that not only old people would die, that operating rooms were converted into ICUs in Italy, that the tsunami would come and would soon hit us in Germany as well, and that the big wave was about to come, and they were hoping that the government would react quickly in order to take the restrictions and the necessary steps in order to avoid a big damage or a big tsunami for Austria, Switzerland, or Germany, or the more northern countries. And although Europe is not Europe and we have the different countries, most of these countries reacted quite quickly, and they decided to have a consecutive shutdown across all the countries as of mid-March. And now we are discussing whether this was soon or whether this was late. And obviously everybody who wants to criticize the politicians would say it was too late. But in fact, it was really in time. And I think that we have done quite well with the timing of these decisions. The consequences, as in the nature of a pandemic, was that we almost abolished all the democratic structures. It was a top-down decision. We suddenly had these committees, as you have, the virologists, the epidemiologists, and intensivists were the advisors. Surgeons had to step back. We had daily updates with all these dashboards. And we observed a severe resource reallocation to potential COVID-19 patients. These measures were taken when, for example, in Berlin, there was 0 patients, and in Germany, we had 16 patients that were contracted. And already by that, beds were converted into ICU beds, and the personnel had to be shifted to regular wards. And we had to triage. We did not have to triage whether somebody would go on the ventilator, but suddenly we had to triage our surgical patients, which in our eyes, or especially in my eyes, was not minor problematic. This is what Carlo Schaller has shown on a recent WebEx meeting, how Geneva, for example, developed. By mid of March, they were down by 80% to 20% of their elective program. Their physicians were in fact becoming COVID doctors and had to rotate to the ICU. And then the healthcare personnel got infected, and they reported a significant amount of patients dying, even below the age of 50. So they really mirrored what was going on in Italy. And the Italian group by that time, or in their publication that I'm going to show you, had this quote: "Neurosurgeon might feel fairly useless," and we felt useless. And Michael Lawton on his homepage, or on the web, posted for the BNI that there's a restricted neurosurgical education and that neurosurgeons would sit on their hands. So neurosurgeons were in a situation that they really lost activities, beds, and work to do. The interesting observation was that we had North Italy being affected very heavily. It was less severe in South Italy, and we had some other centers here around the Alps, like in South France, or here in the Alsace. But in contrast, in Germany, on the other hand, on the other side of the mountains, there were at the same time hospitals where patients were showed up in a very low number, or there were no patients on the ICU. At the same time, when in Italy, obviously there was the tsunami already going on. And the question was, what's the reason for this kind of heterogeneity? And I think even looking back, we'll never have a good explanation, or we'll never know for sure. I think in Germany or in Austria, we were in first line, we were lucky, and we have to be grateful that we were not hit so hard. One reason might be that we missed some undetected incubation periods. For example, in Alsace, in west of France, the first patients that had the symptoms and retrospectively were already COVID-19 patients showed up in November and October. And obviously they had a much longer incubation period undetected than we had. Maybe it's the cultural differences why Southern European countries are affected more heavily than more the Northern European countries that are maybe more distanced than the Southern countries. And of course, we were discussing whether there were some super spreader events. For example, one of the Champions League soccer match in February has been shown to be a super spreader. Then at the same time, there were big demonstrations going on in Paris, in Tyrolean area in Austria. There were the big skiing holidays with the post après-ski parties, and many patients that then came, or many people that came from Austria to Germany got infected during these parties. And at the same time, in Berlin, we started quite early with social distancing, and we were lacking these kind of super spreader events. The next thing is that maybe there were differences in structural health care issues. And if you look at the organization of the public health systems in the different European countries, and here you can see the amount of intensive care unit beds per 100,000 people, you will notice that Germany has approximately, by tradition, the highest number of ICU beds, and this is 30 per 100,000 inhabitants. And on the other hand, you can see the countries that have 1/5 or 1/6 of these number of ICU beds. And within a few weeks, Germany scaled up from 30,000 ICU beds in total to 50,000. And this was an increase by 60% already coming from a high number of ICU beds. And here you can see a correlation of the number of ICU beds and how the different countries did in terms of mortality or fatality rates. And you can nicely see that there is a slight correlation. The higher the number of ICU beds, the lower the risk that patients will die from COVID-19 and the mortality will go down. And these are important lessons that have to be learned for future similar situations or similar crises. This is another graph showing how many beds we had per patient. So Germany, for every patient that was contracted with COVID-19, there was one ICU bed ready in case the patient needs the bed. And you can see, for example, in Italy, only one bed was for 8 patients. So this is the difference that was also maybe influencing the course of the pandemic in the different countries. Then, of course, we learned that testing is mandatory in order to contain the infection chains. And it was a big luck that we had Christian Drosten. Christian Drosten, as a young virologist, he's now the chairman of the Department of Virology in Charité. But many years ago, when he was already still a resident, he was the one who was cloning the RNA for SARS virus #1. And I believe that he was just waiting for SARS-2 to show up. And this is why he was the first one to describe and to put into the public domain the RNA-based test already in January. And this meant that the testing strategies in Austria and in Germany were very intense and very early in order to identify infection chains. And meanwhile, he has really become a hero. And he, from a not well-visited Twitter account, he has now 400,000 followers. So he was really one that really changed maybe the course of the disease here in Germany. And then obviously, very soon, the countries in a different way started to separate COVID negative and COVID positive patients. For example, this was one of the problems in Italy, the big centralized hospitals, and then intermingling and mixing these patients. So what did that mean to neurosurgery in Europe? So Marco Fontanella from Italy, at the very early phase, started this kind of survey. Meanwhile, these surveys have been done by different groups in different disciplines, but he started in mid-March, and he surveyed the time between March 28 and April 5, and he asked 17 questions, and he collected information on the nations and their involvement by COVID, how much neurosurgeons were restricted by the pandemic in the different countries. And the primary goal was really to assess the neurosurgeons' perceptions and how they reacted. And number two was to correlate the data and the epidemiology for each country. These were the countries that were taking part. And as you can nicely see, many countries took part. And interestingly enough, the intensity of the pandemic in the different countries did not have an influence on how the participants answered the questions, how much they engaged. But interestingly, you can see here the statistics. These are the countries that answered more questions than necessary or than expected. That means that they wrote additional information. And these are the countries that were not answering all the questions, or in other words, they were less engaged in the survey or maybe less emotionally engaged in the pandemic. At a time point when in all the countries, the pandemic already had taken off. So the blue ones and the red ones, the spots are the time of the survey. And as you can nicely see, whatever country you look at, the pandemic was already in its logarithmic growth. And everybody was already under the impression of what's taking place. And the most interesting question was, how did the neurosurgical practice in the different countries change? Here you can see the hospitals. Many reduced their elective program, very little really centralized, and had hospitals that were only devoted to COVID-19 patients. But here you can see the heterogeneity in question 14. How did it modify your surgical indications for non-emergency surgery? So how was the elective surgical program affected? And you can see many of the countries were affected by 80%, 100%, and Germany was affected by less than 20%. And similar, but not as impressive, how the neurosurgeons dealt with the SAH. There were even countries that changed their approach to the SAH patient during the pandemic. And the study also showed that there was a heterogeneity in screening. Large hospitals became in part super spreader institutions. So this is one very important lesson, that those countries that had centralized academic centers where all these patients were canalized, these hospitals were completely contaminated. So what we might learn in the future is to improve on the periphery and not really focus on the centralization of our regular healthcare system. There was a heterogeneity in the healthcare personnel affected, and most of the responders described a reduction in surgical activities. This is what happened in Berlin. In February 1st, there was no case, while 16 cases had been identified in Germany. In March 12th, we started already with social distancing, not yet as a rule, but only as a recommendation. In March 25, there was a moderate lockdown. It wasn't a lockdown as in Italy or Spain, where we were not allowed to leave our apartments. It was a moderate lockdown. And we still forget that in Germany, when we start to maybe look critically at the lockdown, it was a moderate lockdown, and we were happy that we got away with a moderate lockdown. And those that had to decide did a pretty good job. By April 15, there were more than 4,000 cases and 100 in Berlin. And by June 1st, we had 197 deaths and 8,511 deaths in Germany and almost 200 deaths in Berlin. So it was not as dramatic as in other countries. But still, all the preventive measures were still taken. There was a nationwide reallocation of medical resources. This was already done when we did not have one single patient in Berlin. This was done at a very early time point, that neurosurgical staff, OR staff, and nurses were reassigned. We saw new wards being created for pre-COVID, post-COVID. We saw new beds turned into ICU beds, and not in the OR, but in separate buildings. So the OR capacity was not touched. It was just turned down because we lacked the personnel. And 30% of the regular hospital beds, Charité has 3,000 beds, and almost 1,000 beds was reserved for potential COVID patients. So at a time point, we had 1,000 beds being empty and waiting for the COVID patients. And the surgical capacity was reduced by 50%. This was a challenge because the Charité is a conglomerate of 3 different hospitals, and neurosurgery, and our team is responsible for the neurosurgical service at these 3 hospitals in the south, in the north, and also in the north, the trauma center. So we had to find a system where the residents and the faculty would never meet, and there was no risk of contamination. So we organized the faculty and the residents, again, very early in February in silos. So we had teams designated to different campuses, and they never met. We had one clean team in home office for 1 week, and then they changed in order to have a clean team in case that we would get into trouble and we needed non-contaminated personnel. There were no rotations, no coverage. We had video conference calls already in February. There was a voluntary limitation of social interactions outside the hospital, and we were hit in a way that 2 faculty members were in quarantine because they had respiratory syndromes, but they turned out not to be COVID positive. They were COVID-19 negative, but they were in quarantine for 2 or 3 weeks. That means our slim team of 14 faculty members was split into cohorts of 2 to 3 members covering 7 and 24 hours. And still, the group that I've mentioned, like Carlo Schalla and Bernhard Meyer, we all felt that we were in a mode of resistance. We did not want to accept that we should not operate on neurosurgical patients anymore. We felt that most of the neuro emergencies are urgent. Even if somebody has a disc herniation and has bladder problems, has a myelopathy and is unable to walk, these patients needed to take care of, and they deserved our attention, even if they were COVID negative. Time is brain and time is spine, so it had to be quick. And we were aware that this would create a complete lockdown of medical service, would create collateral effects, and we wanted to avoid that they would outweigh the disease. And this is why Germany was at 20%. And we also felt that this is a test of system relevance. This was a test of time for the system relevance. What means system relevance? This word became a buzzword in Germany, and it was coined by Chancellor Merkel at an early speech in March 18, before the lockdown of the country. And she acknowledged those that kept the country or the engine running, those that were taking away the waste, those that were in the supermarket, making sure that everybody had something to eat. And maybe also the personnel in the hospitals that were taking care of the patients. In other words, what is irrelevant for the system is when you shut it down and nobody had missed it after 12 weeks. And we felt if we shut down neurosurgery, and what would happen after 12 weeks if politicians and health politicians would argue that nobody realized that neurosurgery was really missing. And this was why we always tried to define our indications and to broaden our indications where it's possible. The first step was to introduce this kind of consensus statement from the German Society of Neurosurgery, and we identified neuro-oncology, neurovascular, spine, and you can see the indications and you can read the indications, and we defined what has to be taken care of. And this was sent to politicians, and we had an agreement that we would take care of these patients. We would never become COVID doctors and not take care of our neurosurgical patients. These were the patients that we tried to take care of to reduce the collateral damage, and we used the limited resources, and we operated day and night with 2 to 3 surgeons in one group. And that the collateral effects would come has been shown now, and it's ample evidence now. For example, here, this is a German paper saying in Germany, more than 1 million surgeries were canceled. And this is obviously hitting at the oncology area. In Germany, 85 of elective surgeries have been canceled, and 26% of oncology cases have been canceled. And this is the worldwide the worldwide situation after the collateral effect of canceled surgeries, COVID-19. You can see the total numbers that are estimated of surgeries that were not performed, which is obviously detrimental, especially in the field of oncology. And this was decided at a time point when nobody really knew for how long this crisis would go on. This is another data from the neurovascular field, the stroke treatment, and you can nicely see from the software used, categorizing patients coming in with stroke, that you can see the dip in treatment of these patients. And you can see similar things with heart strokes, with heart infarction, cardiac infarctions. And then there was the discussion whether these patients are just at home and feeling well and they are not stressed. But this paper really shows that patients were scared to death coming to the hospital and they died at home from cardiovascular complications or cardiovascular accidents. And you can see this paper from Italy showing that in 4 regions of Italy, in North Italy, during the COVID-19 pandemic, there was a triple increase of patients dying of cardiovascular accidents at home because they were scared to go to the hospital. And in those regions that were heavily affected, this is what happened in 2019, and this is what happened at the same time period during COVID-19. So I would say that this is not only a collateral effect, this is a real collateral damage of COVID-19 and reallocating medical resources. What happened to neurosurgery? I will give you 2 examples. This is a patient, 51-year-old. He had lower back pain, fever, shivering, and he was scared to go to the hospital, was treated by his GP with oral antibiotics until he was admitted because he couldn't stand the pain anymore. Obviously, he has this spine infection, the spondylolisthesis, and by the time he reached us, he also had an endocarditis, and which has aggravated. Still, the valves are working, but this is obviously one of the COVID-19 victims because this patient would have been treated 4 weeks earlier. We could have identified his bacteria and his pathogen and could treat him in time. This is another patient, prostate carcinoma. We operated him on March 25 when he came in with an acute spinal cord injury, paraparesis 1 out of 5, 360 instrumentation and vertebral body replacement. We used carbon peak screws and this distractable titanium cage. He recovered well within a pretty short period of time. He was discharged for rehab and everything was set up for his radiotherapy. Patient came back to us in May, again paraplegic. He had a significant tumor recurrence and spread. And the reason why, because he was not treated by the radiotherapists due to the shutdown of the COVID-19 pandemic. He was told that his treatment was deferred until everything was open again. And then he came back again paraplegic with a tumor recurrence, another COVID-19 victim. So we analyzed this collateral effects, assessing our performance from February 1 to April 15, 2019 and 2020. And we looked not at the elective surgeries, but at the emergency and urgent surgeries as we had defined through our German society. And we then assigned 1 to 6 disease categories. Here you can see that the number of admissions went down from 19 to 20 by almost 50%. And this is the same whether it was an emergency case or whether it was an elective case. That means we were still operating on elective cases that we described as urgent or that declared as urgent, and we had emergency cases, but they also obviously went down. Interestingly enough, most of these patients came through the ER, and the referrals went down because the referring doctors had closed their private practice and we had reduced our outpatient clinics. Here you can see vascular, oncology, spine, trauma, hydrocephalus, infection, and others. And you can see nicely that the ratio between, or the percentage of the different disease categories stayed the same. So that means it affected all these disease categories, and even those patients that were treated surgically and non-surgically remained the same. On the other hand, this graph nicely illustrates the difference. Here you can see the total emergencies, and you can see the difference in emergencies reaching the hospital. And this is not because other hospitals took care of these patients. This is because these patients never reached the hospitals because they stayed at home and were or did not reach the hospital in time and died at home. It was not so prominent for the vascular, not so prominent for oncology, obviously very prominent for spine, not so prominent for trauma, hydrocephalus, interestingly, but there was always the trend. But on the other hand, it shows that these emergencies really showed up, even in the worst time period of the COVID-19 pandemic. These cases showed up and we delivered the care to these patients. So that means neurosurgery was system relevant the whole time and these patients were treated. We looked at the difference in those patients showing up, and here you can see the time interval between the start of the symptoms and the admission. And there was a significant increase in spine. That means patients with spine problems simply waited longer until they went to the hospitals. And you can see the similar trend for vascular emergencies. So patients staying at home, risking that they would have more complications, dying because they were scared to go to the hospital. And this shows you that those patients that had severe neurological deficits showed up, while those patients that had pain stayed away. So it's a function of the intensity of the symptoms. And the same is true for vascular, hydrocephalus, and trauma. Here, this is the use case of SAH, and this shows you that SAH was treated very similar. So we had approximately 10 cases in this time period, in both periods, and the same percentages and the same way how they showed up, and they were treated the same way as in 2019. In contrast, we picked chronic subdural hematoma because we all know that these are not so dramatic cases and they come in different flavors. Some of these patients have headaches, some of these patients have a loss of consciousness. And here you can nicely see that there was a significant decrease in chronic subdural hematomas, which was significantly different. And the further analysis of their symptoms showed, again, those patients with headache or vertigo did not show up, 40% versus 14%. And only those patients that had a reduced GCS or had significant neurological deficits, they would show up in the ER. And this is the one where we can show that this had consequences for the outcome of our patients, a significant drop in good outcome between 2019 and 2020, and more patients had a adverse outcome because of the pandemic. And this again is a collateral damage of COVID-19 pandemic. So what's the personal view and what are the personal consequences? Do I feel that post-COVID will be pre-COVID? Certainly, I don't think so. But this is what you can see everywhere. Less traveling, okay, we'll travel less, there will be more video conferencing and so on. You can hear that from many talking about this topic. And we have started our virtual grand rounds. This was Andreas Lozano, our last visiting professor. Here you can see we don't have to bring people or professors in. We can share information very easily and we can reach residents and faculties over a long distance and improve on education. But what will remain and what's the relevant stuff? Number one, I believe that the concept of system relevance will stay. We have a certain feeling that what happened, some disciplines stopped surgery completely, others continued, and it has been shown what is really relevant and what is necessary from the system, even in times of crisis. There are plans to prioritize, not necessarily by us, but by politicians. We take closer looks at our outcomes, at the costs, and we will analyze the costs versus the relevance. This is what is going to come, and we will not be able to affect this. My individual view on this is that certainly post-corona is not pre-corona. I feel that my individual attitude has changed dramatically. Things that I had accepted over the last 13 years of chairmanship, I am now questioning, and I'm now completely rethinking how we are organizing ourselves. I can see many colleagues and many disciplines where referral networks are going down. we all thought that as soon as we reboot the system, and we are in the state of rebooting for the last 4 weeks, and guess what? Some of these disciplines that were not active have lost many patients. Either they were operated somewhere else, or the referring doctors, or even the patients think that these are still COVID hospitals and they would never go there for further treatment. The market has significantly changed, and even the patient perception. We strongly believe that from these lessons that we have learned, the healthcare system has to be reorganized. We need better networks. We need centralized academic centers, and we need the periphery. We have to improve, or we have to better define what peripheral hospitals should do and what central hospitals should do. We all strongly believe that not every COVID-19 patient has to be treated at an academic center. We should strengthen home care. We should strengthen the periphery in order to prevent collateral effects by flooding our academic centers by these patients. And for sure, these patients may come in the future again. And this is why the government has decided to support with 150 million Europe a network project all over Germany. Again, you can see Christian Drosten and the Charité CEO. And the idea is really over the whole Germany to improve on these networks and to strengthen the interaction between centralized medicine and peripheral medicine. And finally, we have to find ways how to better allocate the resources in future waves. And we have to reconsider the concept of super specialization. I've shown you that we tried to master all these patients with 2 to 3 faculty members over 1 week until the new team came in. And this really asks whether super specialization as we have it today really makes sense. Because as soon as you have the oncology specialist or the vascular specialist contracted or being ill, your whole system, your whole organization of high complex surgery or high complex medicine fails, and you will not be able to take care of these patients. So this is really a plea for again, broader treatment and more generalized treatment and less specialization. What about surgery? What will happen about surgery in post-COVID? We have shown, or we feel that neurosurgery has proven to have a high degree of system relevance. Neurosurgeons will be needed, and neurosurgical care will always have its place, even in the worst pandemic. We have seen that neurosurgery is a specialty with highest complexity, and it has the highest CMIs. So it's also important from an economic standpoint. We know that already now 20 to 30% are high-end cases, which is a unique selling point. And this is why neurosurgery always has to stay in these centralized academic centers, while we have to discuss what we should outsource into the periphery. We have shown that neurosurgery is a use case for surgical digitalization. David obviously is a role model for surgical digitalization, innovation in this field. Neurosurgery is the area where we have the highest investments needed, and we treat many rare diseases. And this is why we strongly feel that neurosurgery has shown that it's needed. Neurosurgery will never vanish, and neurosurgery is the discipline for the centralized care, and it's a prototype of academic medicine. And these are my personal conclusions from COVID-19, and this is the line that I'm thinking for the future organization of neurosurgery specifically, and healthcare organizations in general. Thank you for your attention.
That was great, Peter. Tremendous presentation. I will always remember that Europe is not Europe. You talk about the long-lasting, actually the collateral damage to patients, but also what's your opinion on the long-lasting effect of what has just happened in terms of education of residents and medical students?
That's what I mentioned briefly when I say that we will see less traveling and a better education. We have all these virtual meetings. We have the opportunity to invite visiting professors, and this will improve on the teaching. On the other hand, we will miss these personal connections, and we will miss this intermingling and discussing topics in more detail at the coffee break. And I'm not yet sure whether this development will be as positive as we think that it might be.
And I think also the, our New York, well, I looked at we had the same kind of feelings about the importance of non-COVID treatment. I actually had that discussion with you in March, but our problem was we had the beds were just we knew what this was coming because we were late. And so there, by definition, was a different ethic because, and I think there were lives sacrificed, which you just beautifully demonstrated. Same thing in New York as Germany, same problem. But it took longer for us. We're still not doing elective surgery, and I think that actually the whole concept of COVID fear and if it's a COVID hospital is a problem. How do you think that just the fact that you were doing the cases prevented the public from seeing you as COVID only? Did it work? Was it one-to-one like that, or was it something that you really had to promote and say, hey, that that whether you have a heart attack or a COVID case, we treat you just the same?
So don't get me wrong. I think it's the decisions that were made were without an alternative. I think these decisions had to be made, and they were the right decisions, and we should be grateful that they worked for us all. And I also appreciate that with the hospitals being flooded with these patients, there were also no alternatives for you. But what my argument is rather that we should learn how we can improve for the next pandemic, because this might happen again, and we should improve our structures and learn from it, and discuss how can we distribute better the patients and guarantee the treatment for those other non-COVID patients that need the treatment. So I think we have to learn a lot of lessons. We realized it started with heart attack, then with stroke, that patient numbers were going down, and we advertised in a way and tried to ensure that hospitals are still safe places. I think the strategy was really to leave such a strong impression on the population and tell them they should behave correctly. And this, we really needed a joint effort, that they were scared and they were afraid that the hospitals are really contracted or they are contaminated. And this kept many patients away. So we tried to really advertise actively, but on the other hand, it was difficult to reach them all.
Okay. Well, it was great. Thank you for accepting the invitation. Awesome.
I know how hard you worked on this. It's a lot of work, and really appreciate it. Hope to see you with a beer in my hand again someday soon.
Thanks for having me. Thanks for having me. Bye-bye.
I'll wear my lederhosen.
Okay. So next we have Dr. Steinklein. Jared is a neuroradiologist who came to Lenox Hill in 2015 after completing a fellowship in neuroradiology at Emory University. He returned to Northwell after residency training at North-Shore LIJ. He's an active participant and presenter in our weekly cerebrovascular conferences. He's a critical member of our team in any decision making that we have in terms of our management process for all of our cerebrovascular patients. He has particular interest in head and neck imaging, vascular malformations, stroke, and inflammatory disorders of the central and peripheral nervous system. He's also a proud educator, serving as the Associate Program Director of the Radiology Residency Program at Lenox Hill Hospital when he was awarded Teacher of the Year in 2019. Pleasure to have you participate in this webinar. You're going to be talking about neuroimaging findings of COVID-19.
Pleasure to be here with you all. Thank you again for the invitation. Let me just start sharing the screen, hopefully. All right, are we good?
Perfect.
All right, great. So I'm going to quickly go through this. There's a whole lot to show and talk about, and I have no disclosures. So the objectives today really discuss what happened to our division and Department of Radiology at Lenox Hill Hospital during the pandemic, the challenges that we faced and the achievements that we reached. I'll blitz through the neuroimaging. There's so much to show, really varied pathology we saw, and it came in waves, and I'll review that. And also go over some of the recent literature and how we should look at that critically. And lessons learned from this. Does the imaging and the pathology we're seeing offer insight into the neurosequela of COVID-19? So to be allegorical for a moment, it really was a storm. It really did kind of come as forecasted and then just hit us out of nowhere. And the literature kind of used that allegory. So we as radiologists are detectives. So we were critical in managing these patients. And it was a new normal for us. I'll never forget Friday the 13th, March 13th. We were working from home, disrupting the workflow, disrupting communication and interdisciplinary care and education, and everything turned web-based. This was a new virus. We were seeing patterns unfamiliar to us and really confusing pictures, both clinically and radiologically, requiring a lot of collaboration, which is still ongoing between institutions and between ourselves. Some of the challenges were, the utility of imaging. CT was used quick and easy in the ER, but, can look for hemorrhages and large strokes, but really was missing the boat in a lot of these patients with confusing and confounding, neurologic problems. And MRI proved challenging. These were very unstable, critically ill patients who really weren't able to stay, motionless for the full exam. We did tailor the exam for some of these patients. And fortunately, on the third floor, in the radiology department, we have 2 of each, MRI and CT scan. So we did kind of designate one for COVID and one for non-COVID patients. The PPE shortage was minimal. From what I've heard from my colleagues around the city, we really were very successful. So kudos to all the RN leadership in managing that. And most of all, it really was an intellectual challenge. Things we've never seen before, patterns that are new to us, requiring a lot of collaboration. Here's a text message I received from one of the MRI techs and the MRI manager sitting here. We will make it. They were very proud to be involved, and we're proud to stand behind them. So here's a chart that's been referenced earlier in this morning of the dashboard, which Dr. Baker had, emailed us early on and reminded us to view, to track our progress. For neuroimaging specifically, phase 1, we saw a decline, and pretty rapidly. And then phase 2, we started seeing an unusual percentage, an increased percentage of strokes and hemorrhages as these patients became more complicated. And this last phase, which has kind of been, uncovered in the last month, 6 weeks or so, is the encephalopathic patient. And that is most challenging for us, trying to decipher, what happened, what is happening. Is it still happening, and will it happen again? So that is a prolonged phase. And again, bravo for this curve. I think it's just tremendous. So changes in workflow, we did see a steep decline in neuroimaging. Less stroke codes was quite noticeable, and this was a New England Journal article pooling all the data from Rapid, actually showing the steep decline that we saw in March into April. And socially distancing, we've been reading remotely since March, and from that we've had web-based collaboration of interdisciplinary conferences. There was a tremendous disruption to our resident education. We have 16 of them, so teaching them remotely was a new normal and a challenge, and half of them were actually redeployed to the units to assist in COVID care. Becoming a neurointensive radiologist was a new job title for us. We were looking at chest x-rays, and this was an article published in AJNR by colleagues in a few institutions showing the decline in the neuroimaging volume. And we were acting as radiologists with less neuroradiology to read, so reading chest x-rays was becoming the normal. This wouldn't be possible without teams. So Friday the 13th, I said before, you'll notice within a few days, we were already sharing tumor board lists and cerebrovascular conference lists. So really have to thank David Langer for his leadership during this. And I will joke that teams at first, at the end of last year was kind of a nuisance. Why bother? Just call us, just come down, see us face to face. And now it's not even, it became impossible. So the fact that we were already equipped with teams and familiar with how to communicate was vital. And as we learned, the storm kept rolling. It's not just a pulmonary disease. So reports in late March and April started showing that, you know, a third or more patients had neurologic manifestations, and impaired consciousness, again, is the one that kind of confused and eludes us. More reports from neurology showing a varied list of neurologic symptoms, and, you know, other reports from Europe as well. Here's a case that was published in Radiology of acute hemorrhagic necrotizing encephalopathy. And I haven't updated this yet. I think it's over 200 times that this has been recited and referenced. And to be honest, I'm not quite sure if this is a pattern that we've seen throughout our searches. There are a myriad of imaging findings. So in the first phase, we saw a lot of incidental lung findings. In the second phase, we saw the strokes from hypercoagulable state, and also patients, you know, with consumptive coagulopathy and you know, treatment on anticoagulation with pretty catastrophic hemorrhages. And in the last phase, again, continuing phase, there's leukoencephalopathy and para-infectious processes that are ensuing. So here's a case, completely incidental finding. We were doing outpatient imaging at the end of March for unrelated, you know, spine workup, and we saw COVID opacities, which you can see are just beautifully demonstrated on the MR and with the typical ground glass opacity on the CT. So first wave, stroke, there was strong evidence coming out that the stroke incidence was spiking with COVID-19. And the literature that we're preliminarily performing here shows that the stroke volumes went down, but the stroke incidence actually went up quite significantly. And again, with all the comorbidities, it kind of makes sense. But what is concerning was the incidence in young patients. So here's a case of a patient coming in for a stroke code. You can see some early ischemic changes in the left MCA territory, very high D-dimer, you know, not doing well and clinically deteriorated and ended up expiring. Here is the CTA showing that the MCA thrombus and occlusion and the perfusion showing the matching defect within that MCA territory. Here's a case of a young patient, 37 years old with really no past medical history, obesity, some gestational diabetes. But the striking thing here is she had delayed coming to the ER. As we've seen in many talks today, patients were very fearful of coming to the ER with these particular markers, prothrombotic state, so not surprising, but pretty small stroke, as you can see on the diffusion. But the CTA shows the cause here, a large, very unusual thrombus in the common carotid artery spanning up into the internal carotid artery. There it is. So and this has been seen, you know, in our community as well, these cases being shared, a very unusual thrombus. Here's a case, left-sided weakness and numbness, came as a stroke code, diagnosed a small cerebellar stroke. It doesn't make sense. You know, they did the workup, there's a hypercoagulable state. So what happened? What is it? And if you look at the neurovascular imaging, everything was patent. You know, there's no evidence of cerebrovascular stroke on the imaging here. But look a little closer, and you can see his left subclavian and axillary artery was abruptly cut off. There was acute thrombus there, and it didn't stop there. So these patients had systemic thrombophilia. The more you look, the more you find pulmonary embolus, aortic thrombus, SMA, superior mesenteric artery thrombus, and, you know, the typical findings in the lungs that we saw with COVID. Young patient, again, 35 years old, no history, had a week of headache, some nausea, right facial numbness, you know, Tylenol and rest, tried to, you know, work through it. Did have a positive lupus anticoagulant. And you can see hemorrhagic infarct here in the right temporal lobe. Subtle windowing investigation, you can realize the hyperdense appearance asymmetric of the transverse sinus. And there it is, hemorrhage on the MRI surrounding edema and infarction with the clot, the filling defect in the transverse sinus. The flow-related signal in this right lateral system is absent. So Another case, sister, companion case, young patient, no history. She actually presents with seizure and altered status. Again, hypercoagulable workup came back positive. Almost mirror image of hemorrhagic infarction with, you can see the methemoglobin signal on MRI and lack of flow signal. Then we saw these catastrophic hemorrhages. So the critically ill patients being treated in the ICU for multiple morbidities with DVTs, pulmonary emboli on heparin, became unresponsive and catastrophic, devastating hemorrhages and brain herniation, as you can see depicted in these examples. And then we started seeing some unusual subcortical hemorrhages, really smaller hemorrhages in more of these, encephalopathic picture patients. As you can see, varied patients, all of those were different. So then the second wave came, and at the end of April, we're starting to see patients recovering from their respiratory disease, but still, not themselves. And some were either unresponsive or minimally responsive and cognitively definitely not at their baseline. And some you weren't even sure what the baseline was because, family wasn't available or wasn't visiting them, or they came, from nursing homes. So MRI findings were very variable here. And there is such thing as critical illness encephalopathy. Is that what we're seeing, or is anything specific to COVID? That is where we started investigating. EEG findings were quite non-specific. I did my own search through Northwell's database, just through our reporting database. So during this 2-month block, searching for encephalopathy or altered mental status in MRI, 330 MRIs were done. 42% of those were COVID positive. Of the COVID positive, half of them were abnormal. So we were seeing a very high percentage of pathology in COVID-19 brain patients. And again, this was later in the peak, late April, and I think it's still going. So the whole kit and caboodle, we're seeing hemorrhages, watershed or vulnerable zone infarcts, leukoencephalopathies, anoxic injuries, PRESS, which is very interesting, I'll get into, and post-viral syndrome. Okay. Here are infarction type patterns, and these are really in the watershed zones or maybe vulnerable zones between territories. They're too symmetric to be embolic here. So the question is, are these perfusion deficits, or is there some fine endotheliopathy and lack of perfusion to this really vulnerable and fragile brain? And that's the question. PRESS has been described extensively in the literature, and typically we see this bioccipital pattern I'll get into. But symptoms vary, and most classically it's seen in labile hypertension, eclampsia, some chemo drugs and immunosuppressive treatments as well. The pathology is controversial, but again, seeing at the vulnerable zones, you think about dysregulated cerebral perfusion at the fragile territories. And it makes sense. The cytokine storm, the endotheliopathy, the leaky vessels, that is the brain at risk. And many faces, as was reported in literature. So here are some examples we saw in our patients. So this sort of bifrontal, bioccipital, and here is a patient published in literature as well with the hemorrhage, but then the follow-up imaging showing some enhancement of infarction change. And hemorrhage can happen in up to 15% of cases. So we call it posterior reversible encephalopathy syndrome. But there was a study out of Berlin last decade showing that about 40% of the time, the imaging actually remained abnormal on follow-up. So, reversible might be a misnomer. Here was a case of sulcal subarachnoid hemorrhage. You can see the hyperdensity in the superior frontal sulcus, matching non-suppression of CSF on a FLAIR MR here, and a little bit of gradient signal from the hemorrhage. Headache, COVID positive, again, no respiratory symptoms or fever. This is a primary neuro manifestation. Had an angiogram, is negative, CTA is negative. So this is a pattern that I think is most compatible with RCVS, reversible cerebral vasoconstrictive syndrome, and that's akin to PRESS. You're dealing with some peripheral vascular territory and small vessel injury and leaky vessel and hemorrhage. This is very interesting to us because we're seeing this in the chronically ill encephalopathic recovering patients on gradient echo or susceptibility weighted imaging. You can see, sort of again at the subcortical watershed areas, little microhemorrhages. And, they would not be seen on CAT scan by any means. And even on some MR without SWI specific, they can be really difficult to pick up. So here's articles from a couple of years ago showing that these microbleeds are seen in critical ill patients, ICU care, encephalopathy in general. And hot off the press, we're seeing this in our own literature as well. Here's a case of hypoxic leukoencephalopathy. So here we see that white matter of the frontal lobe, and this is near the motor cortex, the perirolandic brain, with diffusion restriction. So it's very subtle. I think you may see the punctate infarcts here and there, but it's actually this diffuse injury, hazy signal with dark signal on the ADC map. And a follow-up MRI, you can see the degree of white matter contraction, greater conspicuity of perivascular space. So the global injury was pretty devastating in this patient. Here's another example. So diffuse white matter here. This one extended into the internal capsules, which are vital. So very, we can predict kind of poor outcomes in these patients with major encephalopathies. And is it specific to COVID? I'm not sure. Large scale studies really are needed, and that's kind of the lesson that we're learning from this. Unfortunately, there were patients who had cardiopulmonary arrest either in the field or in the hospital. It was an unfortunate occurrence, and here are some examples of really devastating injuries: total blurring of gray-white, effacement of the sulci and ventricles. Cerebellum may be spared, and you can see the density of it. Here's a case of brain herniation, and this was a case where we were looking for brain death, which is not technically accomplished or legally accomplished with a CTA, but you can see the extracranial circulation is preserved. Meanwhile, there's no flow within the intracranial compartment. Here's a really subtle case. This patient came in with respiratory failure on event, and this diffuse and symmetric abnormality is elusive, and this was actually read as negative. So the MRI findings may lag behind the clinical event, and you can see 12 days later there is global anoxic damage and widespread edema. The patient ultimately expired, unfortunately. So here's the fascinating thing that we're seeing, and I think we may be seeing more of this as time goes on this summer, of a post-viral or para-infectious process. So an immune-mediated response, similar to ADEM, similar to other encephalitides or leukoencephalopathies that have been described, interestingly, in MERS, in another coronavirus. CSF studies so far have been inconclusive, some positive, a couple here and there, but again, they're kind of being done later in the course. These patients, when they were critically ill, it was very difficult to obtain CSF. So here's a typical demyelinating pattern, ovoid lesion, kind of extending perpendicular to the ventricles. If you didn't have any history, this would look like multiple sclerosis any day of the week. They have this typical ring-like appearance, and you can see that here on the diffusion imaging. And then involvement of the brachium pontis is, again, classic for demyelination. Cranial neuritis is something that we started to see. It was reported in neurology in their initial list that came out at the end of March of neurologic sequelae. And I think on Long Island, we saw a few here and there. But here's a patient recovered from COVID, 38-year-old male, but paraplegic, facial palsy, diplopia. I think particularly cranial nerve 6 was the weakest. But you can see on the thin section MR, there's abnormal enhancement of both third nerves. Here are the fifth nerves. And cranial nerve 7th and 8th through the internal auditory canals are also enhancing and abnormally thickened. So this is pretty typical of what we would see with the Miller-Fisher variant or Guillain-Barré syndrome in a post-viral inflammatory process. The same patient, here's his imaging, so you can see a unique rhomboencephalitic pattern, transverse myelitis pattern, and then post-contrast, there's enhancement sort of coating the conus and pathologically along these nerve roots. So here's a case report, a case series from Italy, coming from the New England Journal in mid-April. So they had experienced this wave kind of towards the end of their peak, seeing patients. with Guillain-Barré, and interestingly, their PCR CSF was always negative for COVID. So weathering the storm, can we provide some insight into the pathophysiology? And I think we can. And I think the first wave, the coagulopathy, or the prothrombotic state rather, is definite. I think that's quite clear that that's what's happening in these patients who presented with critical illness. And at the same time, there was an increased risk of hemorrhage. But the encephalopathy, to me and to my colleagues, was really the most fascinating thing. What are we looking at? Is it endotheliopathy and microhemorrhages? And is this akin to PRESS? Is this a pattern similar to what we've seen before? And these are delayed findings in critically ill patients. So there's multifactorial causes to consider. And it really just confounds the whole picture of what we're looking at. And I think the ultimate question, and this will be shown hopefully, in literature and larger scale studies, is there data to support direct encephalitis, direct viral infection of the brain? But for this, no dominant pattern has emerged. So lessons learned from this. It's a novel disease, and it really, the storm allegory really gets to me because it really hit us. And we were not expecting it. Initially there was such a rapid decline in neuro. We said, similar to what the last speaker said, being a neurosurgeon felt useless. Well, being a neuroradiologist was like, felt very, like there was no demand for us. But we found it, and we collaborated. We really, looked to our peers and leaders in our local national communities and worldwide. We're working with some Italian radiologists to really collect the data. Pattern recognition is key. I think that is our primary, job description, finding the common thread and giving insight into pathology, and proceed with caution in interpreting the literature. I think this is just incredible. This number is over 60,000 now, just searching COVID-19 in 2020. If you include 2019, I'm sure there's more. And you really have to think critically about these studies and case reports and case series, and ultimately with multi-institutional support and data, we hope to see solid evidence and causation of COVID-19 and the neuro complications. And interdisciplinary teamwork is essential to the care of all patients, but especially now. So this ties in, and thank you, Raphael, David, and all your team for inviting me here to speak and show you what we've seen and what we can share. And I'd like to acknowledge, my fellow detectives, Dr. Felipe Lee, prominent as Lochauer, and Dr. Lee and Muniz, who provided some additional cases in being the detectives behind the scenes for you guys in caring for these patients. Thank you.
Thank you, Jared. That was an outstanding presentation, beautiful imaging, and very difficult topic, and you made it look easy for us to follow, at least, and great cases. So thank you for your input and your time.
Absolutely, my pleasure. Thank you.
Take care. So next speaker is Dr. Christopher Filippi. Risto Filippi is the Vice Chair of Biomedical Imaging and Translational Science. He's a Professor of Radiology. He's the Chair of an Artificial Intelligence Task Force for the American Society of Neuroradiology and a Senior Editor for AJNR, or the American Journal of Neuroradiology. He runs workshops on artificial intelligence, teaching colleagues about this topic. It is a pleasure and honor to have you part of this webinar.
Thank you very much. Let me get the screen share going. And hopefully we are all set to go. So thank you for the invitation to talk, and think of me as a little bit of sorbet in between your 4 courses of COVID research. I'll talk a little bit about artificial intelligence today, a primer with a little bit of reference to COVID toward the end. In full disclosure, I'm a minority stakeholder in a startup for AI, and I will present some of our findings, but these have all been published in peer-reviewed journals in full disclosure. We'll talk a little bit about how artificial intelligence will transform radiology and is doing so imminently in diagnosis, treatment management, genomics, and talk about some applications for SARS-CoV-2 and how it also can be used to check conscious and unconscious bias. And I'll showcase a little bit of work we're doing at the medical school here at Zucker. To get us all on the same page, machine learning is a kind of artificial intelligence where you give the machine examples, where you give it some handcrafted features, but it learns without explicit algorithmic programming. And deep learning, which is where the field has moved to, you essentially extract all the images and it learns on its own without receiving any input from us, the so-called black box. But you can reverse engineer and figure out what that program was doing. So when I look at these pictures, I see my beautiful dog with a stick, Mount Fuji, and a snowflake. And neurosurgeons and neuroradiologists, we don't really need people to tell us that a tumor is a tumor or an MS plaque is an MS plaque or an abscess is an abscess. What we want to do is to make imaging tell us, is that like an IDH mutated tumor, one that expresses certain genomic properties to make us better than we are. So AI is really augmenting our intelligence. And how does it work? Well, I see my dog, I see the stick, but that's not how computers do it. They see a matrix of numbers, 20 pixels by 20 pixels, a 400 dimensional coordinate image. And the computer says, well, hey, given these numbers in this distribution, what's the probability that that's a canine with a stick in its mouth? It's how the computer's thinking. And it's really based, these neural networks you've heard about in the media, on how the visual cortex works. And just to make it very simple, these inputs are actually imaging features, and they get weighted a certain amount, and it gets passed through this mathematical function. And you have these hidden layers, which are nonlinear functions. It takes little pieces of those images, like representations, maybe edges or lines. It organizes them hierarchically and comes up with a model. So I think this is like a tumor, or more like a stroke. And it compares it to the ground truth, what the image actually is. And if it makes a mistake, it goes backwards here and it re-weights everything. And this happens iteratively over and over again until you have a final model. And it's supposed to act like a neuron. It's trying to get machines to think like we do. Here's a better example. Maybe you have a car, and without getting too specific into the architecture of code, a convolution is basically two mathematical functions, and the third function expresses how they relate to one another in terms of shape. So the first iteration may be, okay, I see the 4 wheels, and then you go through this mathematical process. Then you go, well, now I see the 4 windows, and on, and you have these pooling layers which get rid of extraneous things to sort of reduce the number of parameters and to prevent you from overfitting and being too specific, and on it goes. At the end, it'll spit out, okay, I think it's a car. But, you know, we'll come shortly to an example of one of these image tests. So in 2012 was the big breakthrough. We call it the Big Bang of AI imaging, where they really developed really sophisticated convolutional neural networks. I'll call CNNs from now on, not a news network. And these CNNs would receive millions of images, and it was supposed to learn to identify images without any help. And in that 2016, the past couple of years, these CNNs have won the competition globally, and they have surpassed human level performance at identifying all kinds of images and with a rapidity which we could only sort of imagine. But this slide tells us that garbage in is garbage out. So if you don't give your computer programming algorithm good data, you're gonna have a really bad job. So if you give one of those CNNs little pictures of Kentucky Fried Chicken, extra crispy, and little baby golden doodles, it gets it wrong a lot. So you have to really make sure you train your data, train your network rather, with really good data. So why is AI important? Well, because it doesn't, you know, unlike a radiologist, they're not gonna suffer from burnout, they're not gonna get tired. And the key is that AI programs will see things on an image on a voxel by voxel or pixel by pixel basis that my eye cannot perceive. And it's happening now in the past decade because GPUs have been developed. These are graphic processing units, which are 40 times more powerful than your PC, developed by the NVIDIA Corporation. And it was actually designed to help gamers do games in 3 dimensions. And there's enhanced parallel processing speed. So that's why you're hearing so much about it. So if you want to make a good AI program, the first step is to get really good segmentation. And there are many different ways to do this really effectively, fully automated. You can strip out the skull. Here's a nice example for the neurosurgeons, a typical, you can segment out edema, necrosis, the brain tumor. And here's some examples of AIs that are already in use. And we're testing something just like this currently at Northwell. This was work that I did a few years ago with a large consortium of people around the country. And the message here is that there's no I in team. It always works better when you have a bunch of institutions contributing data. This is a convolutional neural network that uses a bounding box approach. So it actually directs the algorithm with these boxes to find that hemorrhage. It sort of sequentially determines the borders of the hemorrhage and spits out a volume. Here's an example showing you very nicely. It says that, okay, that's the transverse sinus, but it picks up very subtle extraaxial hemorrhage in the frontal lobe here and some very subtle subarachnoid hemorrhage. And those are being used now to change work lists. You can prioritize your work list. Here's an example of a fractal analysis program trying to determine whether a meningioma is benign or malignant. It looks at edge interfaces. So on the right is the more malignant looking. This is just an example of the tumor and its interfaces. It's just the enhancing tumor that's been analyzed this way, and that's more malignant. And you can go to this next example. This was given a special award by our Neuroradiology Society nationally. And again, a large consortium effort using well-curated data sets that are publicly available. So hundreds of glioma cases are put in this repository, so you can do research on these for imaging analysis. And we developed a CNN to predict the genomics of glioblastoma. And it's important to show the CNN. It's beyond the scope of our talk to get into the nitty-gritty of architecture, but I love talking about computer code, so you can always email me later. I'd love it. This is a generative adversarial network. So the best example is counterfeiting money. Not that I've counterfeited, but if you were, you would try to fake the teller. So this is a kind of a CNN gaming program where two different networks compete with one another to see who gets to the ground truth more quickly. One of them generates images, and then the discriminator decides whether they're truthful or not. And you want to always show your code, and these are the results. We had more than 90% accuracy predicting on preoperative MRs what the genetics of these tumors are, and these numbers are currently much higher. We really hope to get that instituted at Northwell soon, and it takes about 5 seconds. And 300 epochs is how much it took us to train it. And here's an example of the images. When I look at these IDH tumors, some that are negative, some that have the mutation, I really can't tell. If I were to do this preoperatively, honestly, it would be a coin toss. And the same for the MGMT status. I mean, these images left and right look so similar to me, I would never get it right. But the computer gets it right over 90% of the time, and it really is very valuable for treatment planning. And this is like the next, I think the new advances that are going to happen soon. And you could do these heat maps showing you the probability distribution of certain genetic markers. And this slide's very important because it speaks to COVID. The best sort of AI programs take a lot of clinical data and combine it with the imaging data into a CNN, and it can really do some amazing things. They took 1 million mammograms at NYU, and they were able to do a better job than mammographers of predicting who would develop cancer a year after an initial mammogram. And when they looked at the clinical data, there were things like thyroid hormone levels that were really important. Similarly, in this particular example, we wanted to try to predict who would have long-term or short-term survival. And we individually looked at things like location, tumor volume, clinical Karnofsky score about how they're doing clinically, age. It wasn't until we added the imaging data that we had about an 80% accuracy at determining really poor prognosis and long-term prognosis. And when you analyze the images further, the single most important feature was actually heterogeneity of the flare signal on a voxel by voxel basis. When I look at these images, I really would not be able to predict how long these patients would survive, but that computer is getting it right more than 80% of the time. And there's a lot of ramifications to that long-term with respect to management potentially. So let's get moving on to the exciting stuff. To me, I think that AI is the ultimate value-added proposition. If there are administrators listening, please listen. This is like, I think, where MR is going to be revolutionized with ultra-fast scanning. Already people are doing entire brain MR scans in under 5 minutes successfully, and spine exams in the same amount of speed, because you can eliminate artifacts on the console level with deep learning and AI, and also motion degradation. And how you do it without getting into the physics behind it, but essentially you undersample case space, use compressed sensing, and a computer program of deep learning, an artificial intelligence program, and you can really increase the speed a lot without losing image quality. And I have some examples. For my good friend in Stanford, we work together on this all the time. And if here's your typical T1 weighted scan, about 6 minutes, and if you do it in half the time, it looks kind of fuzzy. You can then give a deep learning program that image, and it will reconstruct for you what looks like a fully imaged 6-minute acquisition. in half the time. And you can do this for entire brain MR exams and spine exams. And these companies are seeking currently academic partners. Or here's my favorite. One of these images is completely synthetic, one is real, and one has been enhanced with deep learning. I challenge anyone watching to pick the one which is actually the real FLAIR image, and it's actually A. And I think C looks better. Here's another way we can revolutionize radiology. On the left is a fully contrast enhanced scan. Here you're using a minute amount of contrast, use a deep learning program, you can generate what looks like a fully contrast enhanced image. Imagine if you need like 1/10 the amount of contrast, how much savings we could pass on to healthcare. And there's a group in Germany which published virtual contrast enhancement. So maybe we don't ever need to give contrast to get a virtually enhanced scan. And that makes sense. If you assume choroid plexus and pituitary stalk enhanced normally, you can probably generate a contrast enhanced image without the contrast. So let's go to COVID. This paper I read with a lot of interest in Nature Medicine. It's a nice example of using multi-institutional collaboration from Sinai just up the street from us and Chinese collaborators. But there are some good and bad things to the paper. It's great because AI is being applied to COVID, which I think is important because there's tons of clinical data and imaging data. And I think there's rich material there to do predictions of who needs to be ventilated or who's going to do better with a certain treatment or who's going to have better survival. I'm sure that this is happening at Northwell. But there are some problems in this paper. There are very strict standards we've adapted in imaging, both in radiology and the journal for which I'm a senior editor. All of our papers have to show the code. And you have to have a website on GitHub typically where you share that code and make it publicly available so that we can see what you're doing, making sure it's accurate, and then improving on it because we want the field to grow. And it's really critically important to have your like 905 patients actually divided in a 60-20-20 pattern where you have training and validation done on 80% of your data. You reserve 20% that never sees the computer programming at all. It's really sequestered and hidden. This is critically important. If you use all of your data in those three subsets of training, validation, and testing, you'll create a bias and artifactually inflate in performance. And it works better when you have thousands of patients. So here's an example of what we call a saliency map, and it tells you where the computer algorithm was looking. And here it got it right like the radiologist, these ground glass opacities. Here is one where the CNN missed it, but the radiologist got it. What's really important is that AI has to do better than human level performance. We want it to augment our intelligence. If it does as good or not as good as a human being radiologist, what's the point? And so, what's interesting and not really talked about at length in this paper, the senior thoracic radiologist with board certification is far better than CNN for accuracy, way better in positive predictive value and comparable in negative predictive value. So I think that this is a problem. And let me finish by the bias issue. My talk is a bit maybe shorter, but can we use AI for good? I'm an optimist, but I think it's very important when we start dealing with large data sets and artificial intelligence and these kinds of computer algorithms that we're very aware that you need to have balanced data sets that reflect your patient population. So if you don't have enough underrepresented minorities or too many of a particular ethnicity, your program is not going to be generalizable, and it won't be generalizable outside your institution, and that's a big problem. Now, one project that we're doing that's a little bit completely outside the box, which is where I tend to live, is we were asked by the Zucker School of Medicine to sort of develop an artificial intelligence program to predict who would be interviewed for medical school, not because they want to replace the people screening, because that work is far too important to be left to a machine, but rather, can we look at intrinsic or unconscious or conscious biases in our process? And the best way is a machine learning tool, decision trees. And this is an example of a decision tree. You can program a computer to do this and say, okay, let's look at the MCAT score. If you're below a certain value, we'll go to your GPA score. If you're above a certain value, we'll go to the volunteer hours. If you're above 2,000, invite. So you can imagine there are thousands of these kinds of permutations you can do. So you do this, you do these random forest models where you have these tree 1, tree 2, or forest 1, forest 2, forest 3. You majority vote on which one is the best model, and then you sort of apply it to some test set. Even better than that is extreme gradient boosting, where you can do a model, throw in another tree, another model, throw in another tree, and do these iterative gradient boostings of your random forest decision tree modeling, and you can get a new tree at the very end with very little error. And that's what we wound up doing. And here's just looking at all the data. So we had both quantitative data, this qualitative data is actually exceptionally complicated. There's 10 categories. Everything is quantified with certain scaling numbers, 1, 2, 3, based on how much effort was done in certain capacities. GPAs are multiplied depending on the school. So we had 22,000 examples. We put 17,000 to this set, which contained training and validation. These were sequestered and hidden. Then we went through our program, had our final model, tested it on 4,500, and we came up with this sort of graph. Let's go right to the end here. So in terms of accuracy, our AI program worked really well. A negative predictive value was like 99%. But the interesting thing was what we really care about is not so much getting it right in terms of positive or negative predictive values, but rather where things are divergent, right? So here we said these 101 people should have been invited but weren't. So maybe there's some kind of intrinsic bias we're uncovering. And if these 44 we didn't think should be invited but were, is there some hidden bias there? Like I could imagine, like if this were like Cornell, maybe those were people who were like philanthropic donors of some building. They're going to get interviewed no matter what. So there's like ways that we can really get at this data and maybe improve our approaches and make sure that we're not engaged in any kind of unconscious bias. So in summation, I know that my topic is a little bit not strictly COVID related, but I really am very optimistic because I do know of a bunch of AI initiatives at NYU, West Coast, probably here at Northwell as well, looking at all this clinical data and constructing AI programs to successfully help COVID patients. And the key is, you know, it's not optimal for all data sets. You need big data, and to really label it carefully. If you want to make it more publicly available, I would say that multi-institutional sharing is really good, but a lot of places have moratoriums, and that's going to make it really difficult because the more data, the better. Like we have 25,000 head CTs at the RSNA available for images around the world to develop better programming. It'd be great if we could do that for COVID, but it is a little bit expensive. It is hard to do. I don't blame, you know, my friends on the West Coast wanting to monetize their AI program for COVID. There are some regulatory issues with AI if you use it to make a diagnosis, but if it's assisting diagnosis, that's a very easy hurdle to get over. Again, we have to be aware of bias. And for any, you know, AI program that's developed, the really key thing is to reverse engineer it. Look at the last, what we call the fully connected layer of your model. And there you'll see, as we did with our tumor work, that sometimes what you don't expect is like, it will really transform how you look at images. When I found out that flare signal being heterogeneous was the big driver, I look much more carefully now on that imaging around a tumor. So these are all opportunities for all of us to lead, and we really welcome partnership with all of our clinical colleagues who are participating in this really nice Lenox Hill Consortium today. So thank you for the inclusion, Dr. Ortiz. I want to thank all of these neuroradiologists around the country who, with me, are part of an AI task force working with the NIH and other agencies to develop standards and excellence around the deployment of AI algorithms for brain imaging. I want to thank Graham Keir at Manhasset, North-Shore, who's a radiology resident, and Willie Hugh, who's a radiology resident at Lenox Hill. Two of these guys are like Neo in the Matrix because they're fantastic computer coders. And Rona Waldenberg, a neuroradiologist and associate dean of the medical college, who's a visionary in terms of the adaptation of novel technology to improve the processes of the medical school. So thank you very much, everyone.
Thank you, Dr. Filippi. Thank you for the illuminating and innovative lecture. People have been chatting here about your slide of the golden doodles and the fried chicken. And then someone, actually Dr. Shani asked or mentioned, Risto is replacing himself by a computer. What's your comment to radiologists that are concerned with that type of statement?
I think that there is some cause for concern, and certainly, let me answer this two ways. I think that in many parts of the world, and even in America, particularly in places where I grew up in northern New England, they're resource challenged, even in northern Vermont, honestly, and there are not enough specialists. We don't even have where I lived for much of my, all my childhood, there wasn't a rheumatologist, no dermatologist, we had no doctor. So there are no radiologists. When I was working in Vermont, I was the only pediatric neuroradiologist for an entire state and all of upstate New York above Albany. So these kinds of programs could really tremendously benefit small rural hospitals and really elevate the standard of their care for things like hemorrhage detection, LVO occlusion, and stroke detection. But you are right. I think that some radiologists will lose their job if they don't adapt this technology. And I think that we have to refocus how we work and integrate ourselves better with clinical colleagues. We have to provide them with more valuable information. Like, I want to tell Dr. Bookvar on every preoperative scan the genetics of his tumor before he even takes it out. And if we move in that direction, I think they'll have job security, but they can't practice the way that they've always been practicing. I think that that's not realistic.
Okay. Well, thank you so much for the presentation.
Thanks everybody for the questions.
Take care.